In our last video, we looked at the basics of how to insert and manipulate a TEE probe. Here, we'll look at the 4 basic views we need to perform a resuscitative TEE study. I'm Dr. Alex Estelle, and this is SonoCare. Home base for resuscitative TEE studies is the mid-esophageal level. Here, we're sitting behind the left atrium looking out at the heart. With our crystals at 0 degrees, we should see all 4 chambers of the heart, hence this view is called the mid-esophageal 4-chamber view. We usually need a little retroflexion, that is, counterclockwise on the big wheel, to ensure we don't foreshorten the ventricles. We should see the LV apex pinching to ensure we're aligned along the entirety of the ventricle. The mid-esophageal 4-chamber view is akin to the apical 4-chamber view on TTE. It's a good view to assess the systolic function of both ventricles and examine the mitral and tricuspid valves. There are a couple of differences between the views. As we're imaging through the left atrium, we cannot make assertions about its size as it's too close to the probe. Similarly, our alignment is too far off for any quantitative assessment of the RV. While not one of our 4 basic views, a slight clockwise rotation of the probe will focus more on the RV and give us a better view of the right side of the heart. Keeping ourselves in the mid-esophageal position and rotating our crystals to 120 to 140 degrees brings us into the mid-esophageal 3-chamber position. Again, we'll need to retroflex a little bit to ensure we're midline through the LV cavity and we can see the apex pinching. Our view here is akin to the apical 3-chamber and parasternal long axis views. Our main focus here is the left ventricle, mitral valve, and aortic valve. We can also see a little bit of the RV and proximal aorta. In fact, you can see a very proximal type A aortic dissection in this view. This view is particularly good for getting a 2D view of the aortic valve to look for pathology, as well as being able to measure the LVOT diameter for cardiac output calculations. It's also the best view to look for systolic anterior motion of the anterior mitral valve leaflet and dynamic LVOT obstruction. Turning our crystals to 90 degrees and rotating the probe clockwise in the mid-esophageal position gives us a bicaval view, so named because we should be able to see both the superior vena cava and inferior vena cava as they enter the right atrium, though the IVC can be tricky to visualize well. This view is akin to imaging the IVC. Here we can look at superior vena cava variability with changes in intrathoracic pressure as a surrogate for volume responsiveness, sometimes dubbed the rich man's IVC. This view is also great for procedural guidance, as we can see guide wires, pacing wires, and cannulae as they enter the right atrium from the SVC or IVC. We are also able to examine the interatrial septum for a patent foraminovalle or atrial septal defect, if there is a question of right to left shunt. The last of our 4 basic views has us take our crystals back to 0 degrees and advance into the stomach. Here we should see the liver come into view proximally to help us know we've advanced far enough. We'll need some anteflexion, that's clockwise on the big wheel, to help us bring the tip of the probe up to be in contact with the stomach. Here we have the transgastric short axis, akin to the parasternal short axis. The big difference here is that anterior and posterior are flipped, with the inferior wall of the heart closest to the probe and at the top of the screen. With some small movements, either insertion withdrawal or changing the degree of flexion, we can look through the levels of the ventricle to assess ventricular size and contractility, as well as get a cross-sectional view of the mitral valve. Using these 4 views, we can make a fairly comprehensive assessment of the heart and screen for serious pathology. We look at the left ventricle for size and function in both mid-esophageal views, as well as the transgastric short axis view. We look at the right ventricle for the same in the mid-esophageal 4-chamber and transgastric short axis views. We can see the mitral valve well with good alignment for color Doppler in both mid-esophageal views and get a short axis view from the transgastric approach. We can see our aortic valve and left ventricular outflow tract well in the mid-esophageal 3-chamber view, again with good alignment for color Doppler. Our bicaval view provides us a good assessment of the veins coming back to the heart, and pericardial fluid will be picked up easily in both mid-esophageal and transgastric views. Using these 4 basic views, we can uncover any critical heart problem your patient may have in just a couple of minutes. If you're interested in going deeper with TEE, we'll cover more nuanced topics in future videos. I hope you found this video helpful. Now get out there and scan.